I'm Anthony Leeds, and it's been my pleasure over the last few weeks to bring some guests into the studio to discuss some of the questions that relate to problems relating to body weight, to overweight and obesity, and also in relation to diabetes. And as many of you know, globally, we have a major problem with the numbers of people approaching 600 million people with diabetes, many of them who are not aware of the fact that they have it, and who will consequently not manage their diet and other lifestyle factors as well as they might, and therefore will move on to develop the various problems that are associated with diabetes as they become older. And my colleagues and I in the United Kingdom and other countries, particularly in Scandinavia, have been working on how we can best address the problem of helping people to identify their diabetes and then improve it so that in the long run, the outcomes for them are very much better. And much of this, of course, relates to weight. And as, again, many people know, the global population is becoming heavier as the years have gone by. Some countries have seen a rise of an average of 10 kilograms every 10 years, so that if you imagine that over 50 years, that's an enormous amount of weight gain. And this, of course, also means that more and more of the population actually have the problems that are associated with being heavy. And those problems associated with being heavy relate to metabolism within the body, so increased development of diabetes, increased risk of diabetes, increased risk of heart disease, increased risk of high blood pressure and the problems that are associated with high blood pressure like stroke. But there are also some other ones that are to some extent associated with the mechanical effects of being heavy, and also the association between being heavy and also having a higher level of inflammation in the body. So if we take two of those as an example, obstructive sleep apnea is a condition where the breathing stops during the night. In most of us, it stops for 1 or 2 times every hour, maybe up to 5, but much beyond that, it's regarded as being abnormal. Every time breathing stops, the blood pressure goes up a little bit, the oxygen in the blood goes down. And if this happens too frequently, there will be consequences in terms of lower circulating oxygen in the blood for too long, with symptoms like headache and depression, and then also a rise of blood pressure. And there is an association between obstructive sleep apnea and risk of stroke. Now, in the past, this has been addressed quite correctly by using what is proven to be a very effective intervention, which is to wear a mask, which increases the pressure of the air going into the nose and the mouth during the course of the night. Many people are able to tolerate this, but a small percentage have some difficulty with this. However, it is known from some very good experimental work, published, proven work done in Finland and Sweden, showing that a good weight loss will actually cause an improvement in this condition. And this can be done using conventional diet, so a restricted diet, which will result in weight reduction over a period of weeks, or alternatively, special diets, which have been used in Finland for quite a long time now, in Sweden, formula diets, which deliver rather lower amounts of dietary energy than we've used generally in the past. So, for example, it might be an 800-calorie diet in the form of soups and shakes, taken for perhaps 8 or 10 weeks, and as a consequence causing a weight reduction of 10 or 15 kilograms. Now, in Sweden, extremely good work has been done to prove that that type of intervention, a total diet replacement formula intervention of 800 calories, actually does lower weight by about 15 kilograms in men with moderate and severe sleep apnea, such that at the end of it, they were very much better. Now, the machines that increase the pressure in terms of the air that is breathed are so effective that actually in some countries we're not quite as effective at managing body weight as perhaps we ought to be. General guidance is given about. We have very good experimental work from Finland and Sweden, which is published, which shows that the use of total diet replacement formula diets, in some cases very low calorie diet, in some cases total diet replacement of 800 calories, can give a very good weight reduction of 15 kilograms, which can be maintained if there's proper management of the diet and lifestyle afterwards, with dramatic improvement in obstructive sleep apnea. And this is something which ought to be applied more broadly across the globe than is currently the place. The other major condition that is affected both mechanically and in terms of inflammation, is osteoarthritis. Now, many joints can be affected by osteoarthritis, but the commonest ones are the knees and the hips, sometimes also the hands. And in these, there is wear and tear, but there's also inflammation. The problems then are pain and gradual joint damage with gradual loss of function. Now, this is a condition which tends to affect older people. And so with an aging and heavier population throughout the world, but particularly, of course, in Europe, North America and Australia, we're seeing very many more people affected by osteoarthritis. We have no treatments that can actually cure the disease or slow its progress. What we have are medications which can impair the inflammation so that, for example, the pain is less severe. And we are waiting for interventions which will actually slow the disease process. But in the meantime, what happens to individuals is that they slowly progress over 10, 15, 20 years, and then they get to a point where a joint replacement, either a partial joint replacement or a total joint replacement, is needed. Now, of course, 10 to 15 years of gradual deterioration of joint function means that walking becomes impaired, and also, of course, there's a great deal of pain. And individuals with hip and knee osteoarthritis will often have very poor sleep because they will wake at night time. They can't get comfortable in a position at night where they don't have pain. So sleep is disturbed. And as a consequence, some individuals may well develop depression related to sleep deprivation, and basically quality of life is not very good for them. Is it possible to actually improve this by weight reduction? Now, of course, not everybody with osteoarthritis is overweight, but what has been shown in Denmark particularly, and also in the United States and in some other trials done in other countries, is that an effective weight loss of 10 or 15 kilograms can actually reduce the pain and actually improve mobility. In the laboratory, in the department where I work in Copenhagen, in the biomechanics lab, studies have been done which have shown that a 10 kilogram weight reduction will actually reduce the peak loads on the knee when people are walking in our biomechanics lab by about 22 kilograms. In other words, there's a 2.2 kilogram reduction of load for every 1 kilogram weight loss. So in addition to the reduction of inflammation, which is seen, and the reduction of pain, there's also a reduction in the load on the joint, and walking improves. And those who I have seen who have passed through this very effective program have actually said that they didn't realize how bad they had become, and they were not going to allow themselves to regain the weight. They were so impressed by the ability to recover some functions that they had previously lost, and they told me that, for example, some of them were now able to get back on their bicycles and cycle around Copenhagen, and others were able to get off the floor after playing with their grandchildren. Those of you who have grandchildren will know that it's quite important to be able to get on the floor, to play with them at their level, and then actually get up again off the floor. And unfortunately, people with osteoarthritis have difficulty doing that. I'm very glad to be able to tell you that the people who participated in our trial in Copenhagen have actually said spontaneously that they have found that they're able to get up off the floor. Now, for those individuals and others who are still working, of course, being able to bend and get up and down and move about is important in many occupations. And I certainly have had patients in West London who have been restricted in their ability to work by having severe osteoarthritis, and who with the weight loss have actually improved to the point where being able to work is easier again, as well as performing normal functions of life. So that's another area where there is a benefit to achieving a good weight loss. But now, coming back to the question of diabetes, you will recall, those of you who have seen the earlier programs, that Roy Taylor and Mike Lean attended and answered questions and described their experience of the direct trial, where they and a large number of colleagues in the north of England and in Scotland around Glasgow, working in primary care practices, performed a randomized controlled trial randomizing individuals to a total diet replacement weight reduction program of 800 calories per day for anywhere between 12 weeks and 20 weeks. And then this was followed by weight maintenance programs, well managed by healthcare practitioners, for, in fact, up to 5 years. And the results published, so it's all there in the literature for anybody to examine, show that this type of intervention does result in remission of diabetes. That is, a change in the metabolic state and the no further requirement to use drugs, so that they are then classified as not having diabetes. And a high proportion of the individuals, indeed 73% in that first year, were placed in remission if they managed to achieve a 10 kilogram weight reduction. Now, this type of intervention has now been tried in the Middle East, and there's a published trial from Qatar which shows that exactly the same intervention works in people of Middle Eastern and North African origin. And there is already a diabetes remission clinic running at the Abu Dhabi Imperial College Diabetes Center. And there are a number of other clinics in some countries in the world where this type of intervention is being done. Now, the people who participated in the trial in the United Kingdom, in Scotland and in Northern England, have continued to be studied, and we are now in 2021 at the point where the observations are being made for the 5-year time point, and I'm advised that the results may well be presented at a meeting at the end of the year in December, and then it is likely that there will be a publication in early 2022. It's also interesting to note that this type of dietary intervention is in use in Scotland by NHS Scotland, and is currently being trialled in 5,000 individuals in NHS England. And depending on the outcomes of that, it may well be rolled out to a larger number of people in England. So what we have here is the idea of a new approach to the process of considering diabetes. And you recall, those of you who saw Roy Taylor's interviews, that we didn't have to accept that the development of diabetes was an inevitable progressive condition, that it was possible to change the composition of the body, to reduce fat, particularly in the liver and the pancreas, and to enable a recovery of normal or near normal function in the liver and also in the pancreas, with recovery of the cells that produce insulin in the pancreas, and with a consequence that if there was sufficient weight loss and that weight loss was maintained, then there would be a remarkable recovery of function. And Roy Taylor's group has also published a paper which shows that the actual appearance, shape and structure and size of the pancreas returns to normal. So the interesting idea here is that type 2 diabetes is not an inevitable endless sort of, well, not an inevitable progression to a disease which is not particularly pleasant towards the end when the complications occur, but is something that can be slowed down and can be something that is placed into remission. What is also, however, important is to note that we are aware that for people who are overweight or obese, that the ideal amount of weight loss is 15 kilograms, which seems a lot, but the clinical trials prove with absolutely no doubt whatsoever that it is possible for a proportion of people to achieve this. We know that there were individuals who were not able to respond as well as others, and colleagues have been working on how to help individuals who have some difficulty with either the initial intervention or with maintaining weight. And I think that in a few years' time we'll have much more information about how to help people who have difficulty with maintaining weight. But the key thing is sufficient weight loss and sufficient weight maintenance can deliver diabetes remission. Now, interestingly, we also heard from Dimitri Pournaras, a bariatric surgeon working in Bristol in the United Kingdom. And what we were talking about there, of course, was the role of bariatric surgery in managing people who are heavy and who have other comorbidities. And in the United Kingdom, we have a bariatric surgical service, and most other countries do as well. I have to say that some other places like Czech Republic and Sweden actually do relatively more bariatric surgery than is done in the United Kingdom. However, there are published papers that show that bariatric surgery is cost effective in early diabetes, in producing diabetes remission. It's also important to note that for bariatric surgery, long-term weight maintenance has been proven in a proportion of people, and there is data for as long as 20 years in some cases and for 30 years in others. So the Data from Sweden, from the Swedish obesity subjects study, for example, provides that evidence that bariatric surgery is an effective way of helping some individuals. Now, it's also important, and as Dimitri discussed, to make sure that the individuals who are selected for surgery are appropriate and that it is the appropriate type of intervention for them. We also noted that it's important that they be prepared appropriately for the surgery, and it's common practice to provide a diet for people before surgery in order to reduce for example, the amount of fat in the liver, to make the liver smaller so that it's easier to operate, and also simply to make it easier in general terms. So some preoperative weight loss is beneficial. But also there is a need for long-term management after the surgery. So an individual needs to be managed by the surgical unit for 2 years afterwards, and then usually management is passed back to the primary care physician, and it is necessary to have an annual review and blood tests, and also to take supplements depending on the type of surgery that is undertaken. But one of the other points that Dimitri made was that in his view, and I have to say I totally support his view, and that is that we are not doing enough bariatric surgery in the United Kingdom, and it's highly probable that across the whole of Europe not enough bariatric surgery is being undertaken, and there are many, many more people out there who would benefit from surgery who are not actually getting it for a variety of reasons. Now, that would then take me to another question, which is that some of you would say, well, I know people who have type 2 diabetes who are not particularly heavy. And that then takes us back to comments that were made by Roy Taylor and his current experimental work, which is on people with type 2 diabetes who are not obese. They may be slightly overweight or may well not be particularly overweight, but it raises the question of what is the appropriate amount of fat in the body of individuals, and that there may well be there's no doubt about it, a group of people who are not overweight or obese who perhaps have too much fat for being consistent with good metabolic health. Now, his trial is not yet fully reported, but the preliminary presentation that was made at a recent meeting in the United Kingdom suggested that the same amounts of weight loss could be achieved with people who were not overweight, and that their metabolic responses would also be very good. So we're all looking forward to hearing the final outcomes of that. Of course, it will need to be repeated and replicated elsewhere before we start offering weight loss programs to people who are not overweight or obese. And then many of you will be saying, well, of course, do I have to use a total diet replacement program to get these types of changes? The answer is that where conventional diet has been compared with total diet replacement, the retention within the treatment groups is better with the total diet replacement, and that people tend to drop out of a conventional diet program. There's one particular trial undertaken in Melbourne in Australia, which made a direct comparison. It obviously showed that the rate of weight loss with conventional restricted diet took longer, and a smaller proportion achieved the target 15 kilograms weight loss, whereas a greater proportion of total diet replacement individuals actually achieved the target. So it is easier for a greater proportion of people to use the total diet replacement, but everybody recognizes that it isn't necessarily right for everybody. However, it is very interesting that another paper that has recently been, or another study that's recently been reported in several papers, is a big diabetes prevention program called the Preview study, which was undertaken in 6 European countries and in Australia and New Zealand, and involved the recruitment of eventually 2,224 people with prediabetes, and they started by following an 8-week 800-calorie diet. So 2,224 people began the diet in those 8 centres, 6 of them in Europe and Australia and New Zealand, and 91% of them actually managed to complete the initial 8 weeks of total diet replacement. And I think that tells you that under the slightly varying conditions in the different centres, that it is actually possible for a very high percentage of individuals to undertake that type of program. Now, as a result of the initial 8-week weight reduction, which delivered on average just over 10 kilograms weight loss. 2/3 of them, by one set of criteria, were actually non-diabetic at that point, but they were then randomized into another section of the trial, which was to compare diets for 3 years. So they followed a low glycemic index, low glycemic load, higher protein diet, or a slightly higher GI diet and a higher glycemic load diet, and lower protein diet, and then also a higher or lower exercise intervention. So there was a 4x4 design with 4 different groups. At the end of the 3-year period, there was no difference in the weight, the amount of weight maintained. So remember I said that they'd lost just over 10 kilograms. At the end of the 3 years, they had regained around about half of the weight that they'd lost, so that they maintained around about 4.6, 4.9 kilograms, but there was no difference between any of the 4 treatment groups. Interestingly also, only 6% of the individuals who stayed in the program actually developed diabetes, and this in the 3-year period, and this is lower than has previously been seen in, for example, the US Diabetes Prevention Program or the Finnish Diabetes Prevention Program, where the proportion of people developing diabetes over 3 years was slightly higher, but the amount of weight loss maintained was slightly less. Again, underlying something which is also known, which is also proven and fully established in the literature, which is that weight loss is the critical variable in diabetes prevention, stopping people moving forward to have diabetes. And the more weight that can be lost and maintained, the better the results. There are several very good papers that show this absolutely clearly. And what the preview trial showed very clearly was that using an initial good weight loss of 10 kilograms, using a total diet replacement for 8 weeks, is a very good way of starting the program. Now, in addition to the diet, to achieve the weight loss, it's necessary to have a good diet to follow on afterwards. Now, a paper that's just been published in 2021 is one which analyzes the effect of the glycemic index and glycemic load, and it shows quite clearly that being on the lower GI, lower GL diet actually resulted in a relatively greater ability to maintain the weight loss at 2 years. They're very relatively small, about 1 kilogram, half to 1 kilogram, but in a population group and for that period of time, that's really quite useful and quite important. And that then brings us to consider glycemic index and glycemic load. And you will recall that I also was able to talk to Professor David Jenkins from Toronto, who was the person who first described glycemic index back in a very long time ago. I think it was 1983, if I remember the date correctly. And he described glycemic index as a measure of the way in which a carbohydrate food raises blood glucose, tested in a standard way, and there are tables. Glycemic index, we have tables for all sorts of different foods, and for people who have diabetes, it's now usually a conventional part of their dietary program that we encourage them to choose foods which are lower in glycemic index. So they might choose their rice to be a variety which is less, which has a lower glycemic index, so maybe basmati as opposed to some of the other forms of rice. They might choose to use sweet potato as opposed to conventional potatoes. And among potatoes, they might choose those which are waxy rather than floury, because those ones have a slightly lower glycemic index. And they might choose their breads to be ones which are lower in glycemic index rather than higher. So it might require some development of taste in some individuals, but for example, rye breads certainly have very low GI compared to conventional wheat breads, or you could have mixed grain breads and so on. So all of that is there. Huge amounts of work has been done on developing tables for glycemic index, and it is possible that by using this, you can help to regulate blood glucose if you have diabetes. Now, the final point I want to make, of course, is that if you have family members who have diabetes, first degree relative, then it is important to know what your risk is. And throughout these programs, I've been providing web links to the sites which provide information about how you find out what your risk is. At the end of this program, you will find the web link to the Canadian risk calculator, the one for the United Kingdom and the one for India. And my suggestion is that you use this. And if you find that there's a slightly higher risk, maybe visit your general practitioner or doctor and have a blood glucose and perhaps other measurements made in order to determine risk. I'm going to conclude by simply saying that I think that we're now at a very good point. Obviously, we have lots of extremely good drugs for the management of diabetes, a lot of extremely good drugs which in combination can manage diabetes very well, and lots of technological advances with monitoring and insulin treatment for those who need it. But globally, of course, it is the lower income and middle income countries which are faced with a rising rate of diabetes more than the higher income countries. And there aren't necessarily the resources to cover the costs of these high but very potent medicines. And therefore, it's entirely appropriate that in addition to the medications that are used, that we consider bariatric surgery where that's possible and where that can be funded, but also that we use special diets like the total diet replacement that I've described to you. The experimental evidence is all there. There's no reason why it shouldn't be used. Doesn't necessarily have to be hugely expensive. Can be administered in a community centre as well as a primary care centre. So I think we're in a really good place, and I'm very optimistic and very enthusiastic that things will get better, both in terms of helping people who are at risk of diabetes, helping people who have diabetes, and also others with some of the other comorbidities that are associated with being overweight. I think we're looking towards a really good future in this area. So thank you very much for listening, and thank you for listening to all the other guests who have participated in these programs. Thank you. Goodbye.